right. Hello, everybody, and welcome again to another class. Today is, again, we're in RN Nurse 26, Med Surg book, Nursing in Health and Illness. We're focusing on cardiovascular system today, mostly chapter 31 and 32. 32 is more hypertension. A few of the other chapters will be covered in the two more classes that we have later this semester. Infective endocarditis and inflammatory problems of the heart and structural issues with the valves and whatnot. So today is really sort of a general introduction to the cardiovascular system, and you should be focusing and understanding a lot of the concepts in the material within the chapter 31 and 32 of your textbook. There's quite a few objectives. A lot of these objectives are not exclusive only to this class and will be also covered in the second or the third class that we have related to the heart later this semester. We do want to know what the anatomy of the heart is and know where the blood pumps in and out. We want to know the difference between arteries and veins and the structures. We won't go into depth into the endothelium. We'll talk a little bit about it and its role in oxidative stress and inflammatory conditions, which is a lot of what we see with the heart. The mechanisms involved in regulating blood pressure, so we'll look at cardiac output and systemic vascular resistance and so on. That basic equation you'll have to know. We won't go into electrocardiogram or ECGs. I will expect you to know what a QPRS or the T or the ST segment is, but other than that, we won't be covering any of the waves, the lengths, so it's not a telemetry class, in other words. We do want to understand how to obtain subjective and objective assessment for a heart, for a patient that has a cardiovascular problem. We've been covering physical assessments since first semester. You're now in your second, so you should become slightly more comfortable this semester, and you will become more comfortable as the semesters go by. Hopefully to the fourth semester, you'll be able to care for 3, maybe 4 patients when you're doing your preceptorship. We will need to differentiate between some abnormal findings, such as what's a murmur, what does a murmur look like, how do we classify a murmur, atrial fibrillation, and a few others that we'll look at. We do want to look at age-related changes. As we age, what tends to happen? A lot of that has to do with the rigidity of the endothelium part of the vessels and the arteries and the veins. As we age, that seems to be a normal finding, although that can be prevented in many ways. And then we'll look at some of the diagnostic studies. We will not be going into depth. There's a lot to know about these. I'll try to cover a few key things that I expect you to know, but do look them up in your textbook as well. And before we go on into the details of the heart and the structure and the veins and the arteries, I do want to take a step back and remind all of us, remind each other, remind myself why we're here in the first place, right? Go back to the basics, right? We're all nursing students. We will soon be healthcare providers, and as healthcare providers, we really need to always keep in mind the big picture. When you see a photo of an obese person, it's not an obese person we see, it's a person we see who happens to have a problem with obesity. When we see a problem that has any other condition, it's still a person. So we treat the patient, we don't treat the diagnosis. When we do our nursing interventions, we're treating a person. So what is the problem? Remember, we're talking cardiovascular issues. Is there a problem? If there is, where does the American Heart Association, AHA, stand? Where does the American Stroke Association stand? What are the major killers in our country? What are the leading causes of death in our country? Same question. I think you guys can already imagine what the answer is going to be. We're talking about a cardiovascular system and problems here in this lecture. What's the cost? What are we all taxpayers paying for this problem, this cardiovascular problem? Does it matter? Does it matter why we're looking into this, and why? If it does, why? And I do want to make a little bit of an emphasis. I have about 4 PowerPoint slides, and I'm going to start off with these basics before we get into a few of the key things that the textbook is going over. But I think these are important to know because we are healthcare providers, and I believe it's important for you guys as we move into the future to understand what's happening around us, and above all, to be able to give accurate information that is evidence-based. And that's the most important thing. What we don't want to be doing is providing information to our patients. Remember that as healthcare providers, we're going to be asked and we're going to be looked up upon or looked up to in terms of providing data and information of what should I eat, what should I do, what type of drugs, what do you know? And my suggestion is, if you don't know, don't suggest. Say, I can look into that. I'll figure that out. I know how to get the information. I know how to do the research, and I can look up a few things for you and help. Or let me get back to that. But what you don't want to do is give misinformation. And again, the future, there's a lot happening right now in science, and it is imperative that we keep up to date with that science, and keep informed, because we want to inform our patients accurately and based on evidence. And if we don't follow the evidence and keep up to date, then we're going to be actually misinforming our patients, and that's negligence. At least from my opinion, I think it's a form of negligence. So let's look at what the American Heart Association and the American Stroke Association are saying, right? They published this, and I'll give you the references to it. It's on their webpage. They actually now have a nutrigenomics and epigenetics page on their site. The American Heart Association at least does. And so I'd like to take a quick brief look. We do know that nutrients and gene interact, and that can lead to problems. We do know that nutrition is a critical component to prevent cardiometabolic disease. Studies are limited, but studies are happening, right? And so we're moving into an era where personalized healthcare is going to take place, and there's going to be a lot of data that we're going to have to absorb as science finds new things, new information. Let's take a look here. We'll go into, it is hypothesized that many of the effects of diet on cardiovascular disease and outcomes are mediated by change in gene expression. And this basically means that genetics do play a role, but more than genetics, it's the epigenetics, or it's the lifestyle that the individual has or lives by, that will create the gene expression and lead to a disease. Again, as I've said in previous lectures, if you have genetics for a condition, heart problem, in your family, but you have the right lifestyles, you may not necessarily turn the gene expression on, and therefore you're less at risk. You're more at risk by the simple fact that that you do have a family history. But epigenetics is starting to play a major role in whether or not that triggers gene expression of the disease. You may have absolutely no family history of a condition and have a not so good lifestyle, and believe me, it is now believed that gene expression of myocardial infarction, heart disease, or stroke can take place even if you don't have family history of it. So there's a lot of words that are coming out, a lot of new biomarkers that are going to be available. We will cover quite a few of them that we already use in acute care setting: homocysteine, C-reactive protein, BNP, right? And we'll cover a lot of that in this lecture as we go through. But we are looking into the future towards a precision type of medicine, which is going to be personalized and individualized. And they call it the omics revolution because everything finishes in omics: genomics, nutrigenomics, microbiomics. And it's a very in-depth study that as nurses we don't go into, we don't look at it, but there are a few key things that as we start to discover, we absolutely do need to be aware of and pay attention to. And that is our role as healthcare providers, is to be informed and at least not to misinform our patients. So does it matter? Why does it care? Well, yes, life matters, right? Building healthier lives free of cardiovascular diseases and stroke is a goal that we are looking forward to. American Heart Association, American Stroke Association, and many other associations are slowly starting to realize that what we eat, what we do with our day-to-day lives, whether we smoke, whether we exercise, whether we eat certain things and drink sodas and sugars, they all play a major factor, which doesn't diminish the importance that pharmaceuticals, surgeries, and other interventions that you'll see with more frequency in acute or critical care settings play, but they're starting to realize that we need to move upstream and start to look at the problems that are happening and not just deal with the problems after they happen, but how can we prevent them from happening. And nutrigenomics and this new movement to personalized medicine plays a major role. Again, we're not going to go into any depth of this, but I do want to cover a few points in just a second here. So, what are the major killers in our country? Well, chronic disease. We know that. Not acute, not critical, but chronic problems. And those are heart disease, diabetes, and cancer. These are the three leading causes of death and disability within our nation. And down below it just looks at the levels of obese children and in terms of percentage and prevalence, and you can see it's going up, needless to say. And it's gone up significantly more after that last year of 2000, which that study looked at. 2017, straight from the Centers for Disease Control, or CDC, website, number one killer, 611,000 people die yearly because of heart disease. So is there a problem? According to the CDC, there is. And it's a pretty big problem if you ask me. 500,000 people are dying because of these conditions. So what about costs? What does that mean for you and I? Well, 75% of healthcare costs are specifically for chronic conditions. And I'll go back to that previous slide. Heart disease, cancer, and stroke alone are costing us a significant amount of money. We spend about 16.2% of our GDP, that's about $2.3 trillion on healthcare. That is a lot of money, not million, not billion, trillion people, trillions. And in my opinion, this really just reflects how it's a downstream system, right? We wait for the heart attack and the stroke to happen, and then we do our interventions after. And so there's a big move with Medicare to try to put money upstream into interventions that can help patients prevent the heart attack or the stroke in the first place. All of this exceeded the combined federal expenditures for national defense, homeland security, education, and welfare, all put together. That's 16.2 of our GDP, or 2.3 trillion on healthcare. What is possibly going to happen in the future? Well, if by 2023, if we don't change how we do confront this challenge, the chronic health disease challenge, the annual healthcare cost in the U.S. Could be or rise to about $4 trillion. That's from 2.3 to about 4 trillion. That's almost doubling in the next 4 or 5 years, making the cost of care under the current model literally unsustainable. Now, I'm just going to give you a couple of samples about this whole nutrigenomics and epigenetics approach that is happening, whether we like it or not. It's happening. Here I just put 2 images of a Time magazine back in '84. Cholesterol was the big enemy. But cholesterol is just, no, don't eat it. Bad news, bad news. Well, in 2014, as I show you on this Time magazine, eat butter. By all means, eat butter. You got to eat butter. And so what's right? Is cholesterol good? Is it bad? Do we eat butter? Well, nutrigenomics, epigenetics play a role in this, and I think it's important. Some nurses may disagree and think that we don't need to look into this. Well, and I'll explain why I think that they're wrong. So there's an apolipoprotein E, for short we call it ApoE, and there's different alleles of this ApoE. Now, you, me, everybody that is listening to this has an apolipoprotein E. The question is, what type of carrier do you have? There's an E2, there's an E3, and there's an E4. Now, is this something that NCLEX is going to ask you about? Absolutely not. Is this something that I'm going to require you to memorize? Absolutely not. What I want you to understand is the concept here and how it's important, because what we communicate to our patients could actually kill them or make their condition worse. Let me explain this in a quick second. So, is fat good or fat bad for a patient? Well, Should we be telling our patient they should be eating a low-fat diet, a moderate diet of fat, or a high diet of fat? Many nurses out there will say, oh, absolutely, by all means, eat fat. Fat is good for you. Good fat is good for you, right? Or no, you want a low-fat milk, low-fat this, low-fat yogurt. Everything should be low-fat. Well, I'll let you look at this chart on your own, or we can come back to it in a second. But again, the American Heart Association, their statement on nutrition is we need to emphasize that we're moving into an era where we're focusing on how our genes, your gene, my gene, is going to affect you individually. So just look at this bottom one right here. If you happen to have an ApoE2 protein, right, versus an ApoE4, a low-fat diet is not recommended, people. So if you happen to say low-fat is what everybody should be doing, you're wrong. If you happen to have the ApoE4 allele, eating a low-fat diet is very beneficial to you, right? On the contrary, if you happen to have an ApoE2 protein in your body, right? A moderate fat diet is beneficial, very beneficial for you. So again, we're not going into genetics here. We're going into what is happening, where our science is moving us into. You do not need to memorize any of these things, but you need to understand that as healthcare professionals, when they ask us about diet, fat, for example, and I'll give you one more example with caffeine after this. Is caffeine good or bad? Well, we need to understand that where we are already at with our science is telling us that we can't just simply blindly say fat is good for you or fat is bad for you. So what about coffee? Is coffee good or bad for you? Well, let's look at what we have with science before we get right into the heart, because people that you will see on the floor that are coming in for angiograms, that are coming in for cardiac catheterizations, that are coming in because they may or may not need a stent placed, they may have questions like this for you. They may want to know, and in fact, in many cases, especially those who have palpitations, atrial fibrillations, or people who go into rapid ventricular response with their atrial AFib, we don't want them to be on coffee. In fact, a lot of those patients come back from a coronary artery bypass graft and we don't give them coffee. So for coffee, again, just like with butter, right? It depends on what your allele is. Are you an E2, E3, and E4? With caffeine, it depends, are you a slow or fast caffeine metabolizer? And basically, you have a slow metabolizer, and if you happen to be a slow metabolizer, meaning you have that gene, the A and the C, the AC and the CC version of it, caffeine accumulation can lead to high blood pressure and heart disease. So no, people, caffeine would not be good for a slow caffeine metabolizer, somebody who had the CYP1A2 gene, AC or CC. And on the other hand, if you happen to have the CYP1A2 gene, AA, you are a fast caffeine metabolizer, and there's significantly reduced risk of heart disease. So when you see studies out there that say caffeine is good for people or caffeine is bad for people, don't believe it. The question as healthcare providers, again, this is the concept we need to understand. The big picture is, for some people, it will reduce the risk of heart disease. For others, it will increase the risk for heart disease by leading them to have high blood pressure and heart disease. So that's about it in a nutshell. So if you ever have nurses who come in or talk to you, and when you go into these type of details, and they say that talking about, for example, an allele that could affect how you process fat in your body, which is what apolipoprotein E does, or what that CYP gene is that metabolizes caffeine is. As nurses, we don't need to go into details. But if you are a healthcare provider and you're going to be providing nutritional information for a patient that has a heart condition, please stay informed, keep up to date with the information, and speak with some knowledge, or don't speak, because otherwise telling somebody something that they're not in their genes could really be doing them a disservice. And we as healthcare providers, again, do not want to do that. So that said, let's just jump right in and go straight into the structures of the heart. We know there's 4 chambers, 3 layers. There's the pericardium, and usually the left ventricular wall is thicker than the right. And that's for multiple reasons, but it can actually even get thicker depending on the vascular resistance, which we'll get into in just a second. This is, again, should be a review for all of you. Remember that the blood flows really, the right atrium is going to be receiving the venous blood. Remember, the venous blood. It's coming back into the right atrium, and it comes into the right atrium through the inferior and the superior vena cava, right? And then where's the blood going to go from there? Well, it'll go through the tricuspid valve into where? The right ventricle. So up through the top, down into the bottom, into the atrium, down into the ventricle, right? Tricuspid valve is the one in between on the right side of the heart. With each contraction, then the right ventricle will literally eject that blood into through the pulmonic valve, I should be saying, into the pulmonary artery, and then into the lungs, right? So that gas oxygenation can take place. Then the blood will flow from the lungs to the left side of the heart, entering again through the top, the atrium, through the pulmonary vein, and then it'll pass through the mitral valve. The top part of the heart goes through the mitral valve into the lower part of the heart, which is the left ventricle. And what will happen from here is the heart will then contract, and the blood will be pushed through the aortic valve into the aorta and through the systemic circulation. I think if there's anything really important to keep in mind for this right now is left heart, the left ventricle specifically, which is one of the reasons why it's thicker, as you can see in that image, is going to be pumping blood to the body to create perfusion, to take blood, which carries nutrients and oxygen, and to the periphery of the body, to your brain, to your toes. And we already know how to assess that, right? Color, motion, sensation, temperature, pulses, feel with the back of your hands. Is there a perfusion? Is there not? Check the pulses bilaterally, always to compare. If there's no pulses, you use a Doppler, so on and so forth. And so the left ventricle goes to the body. If there's a problem, though, for any reason where there's resistance that the heart is beating up against, then there may be a backup. And at this point, because there's an issue, there's a problem, something that is abnormal, it would go back from the left part of the heart to the lungs. L, left to lungs. So, right, the normal is L to the body, left to the body. But if there's a problem, L, the left part of the heart, will back up into the lungs. Okay, that's a key thing to keep in mind as we move forward. The valves, there's quite a few of them. We're going to go over this in a little bit more detail when we do the endocarditis and the structural lecture on the heart, so I'm not going to go into that into detail right now. Just remember there's 4 chambers, and there's the tricuspid valve, right? There's the aortic, right? On the left side, the mitral valve, and we'll go over this in the structural class. Let's not pay attention to that right this second. And then there's a significant amount of arteries and veins. And when you work on a cardiac floor, it's important to know sort of the location of these, because how and where we put our telemetry strips on the patient is going to depend on whether it's an LAD or left ascending, right? Or a left or a circumflex artery, right? As you see on that left image, there's the circumflex artery and the left anterior descending artery. And so where the blockage happens will make a big difference. All right. Now, when we think of the heart, we not only need to think of it as a muscle, right? A muscle which happens to produce things such as troponin or other the CKMB, other enzymes that we are later going to look at to determine if the heart is having a problem. But we also need to think of it together as a muscle full of vessels, as an electrical system. And literally there's what we call an action potential that creates a polarization, depolarization in the heart. And we won't go into the bundle of His and all of that, but just to know that in many cases there are certain conditions that if the SA node, the one node that should be triggering, right, this electrical impulse isn't working, and there's multiple nodes that are triggering this action potential. If there's multiple areas of electrical impulse happening, sometimes patients will have to take medications to try to control for the rhythm, or even go in with ablation and that laser to just zap and kill the muscular areas of the tissue, the electrical impulses, to bring it back to just one impulse, because the heart gets very confused if there's more than one site of electrical impulse that's triggering the whole move of the heart to create the ejection fraction of the blood and the absorption of the blood back into the right heart. We won't go into the electrocardiogram or ECG. I like to call it ECG. We used to call it EKG, but that's just because in Germany the cardiogram is written with the K. So in the States technically it should be ECG, but a lot of people, you'll still hear them refer to it as EKG. We're not going to go into how to read any of these things at this point. What you really need to know is that where the P is, Q, R, S, T, and the U, and by looking at the graph, you can see where the ST is. It's from where the S is to where the T is. That's what we call the ST segment. And that's important to know as you move forward in your nursing program, because in a lot of telemetry floors, you'll see conditions that can affect that specific area. And so I like this image a lot because the green part shows you where the impulse of the electrical current, remember, electrocardiogram is looking at current. So the SA node that you can see there in green creates an electrical current that pushes that current through the heart up until where the yellow area is, which is the bundle of His. And then that transfers that current further down into the branches, whether it's the left bundle branch or the right bundle, the branch, all the way down to the Purkinje fibers. And that's what we're looking at when we are reading the electrocardiogram, in part. So from a mechanical perspective, we have systole, which is the contraction of the heart, and we have diastole, which is really it's where the filling of the ventricles happens. It's allowing, diastole basically allows for the filling of the ventricles, which is really important. And systole is important because it's the ejection of the blood from the ventricles. Remember, we have two ventricles. One is going to be going to the body from the left side, and the right one is going to be going elsewhere. To get oxygenation and get rid of the CO2 before it goes back to the heart in the left side so that it can then be pumped out for perfusion. Stroke volume is literally the amount of blood that's ejected with every heartbeat from the ventricle. So for the heartbeat, right, the ejection is happening from the ventricles. And so each heartbeat that you have, one push of the heart is going to give you a certain amount of blood that will be ejected. That's called the stroke volume, which is different from the ejection fraction. And we'll go over that shortly. Still considering the mechanical system of the heart and how the heart works sort of as a pump, the amount of blood, the cardiac output is extremely important to understand. And you'll hear that word tremendously, because with people who end up getting cardiomyopathy, congestive heart failure, weak heart for whatever reason, or people who bleed because they're having a trauma, or people whose blood pressure drops, heart rate drops. These are reasons where perfusion won't happen. And that's one way of thinking about it, is cardiac output is dropping. In other words, that blood, which contains nutrients and oxygen that should be getting to your brain, into the toes, and your feet, and your fingers, and your liver, and everywhere else, is not going to be able to happen when cardiac output happens. When cardiac output is decreased, I should be saying. And the cardiac index, we're not going to go into that. You'll probably get that in third or fourth semester with Colin. But basically, it's just a look at the cardiac output divided by the surface area. Again, don't worry right now about cardiac index. Do concern yourself with cardiac output and understanding that concept for now, because it's extremely important. So remember, when we look at at cardiac output, we're really looking at multiple factors. Basically, the heart rate, how fast the heart is beating, the resistance that the heart is going to have to beat up against, right, it will ultimately give you your cardiac output. So one way of thinking about this, I'll take a step back here and try to explain the concept in my own words, is, again, I might be repeating myself, but I think the concept is really important to understand. If you take a glass of water and fill it up with 15 tablespoons of sugar, which is what one soda pop or one soda can has, and you take that glass of water and spill it on the ground, wait a minute, and start walking on it, you step on it, what are you going to feel under your feet? Very sticky, right? Because that's what sugar does. Well, imagine somebody's diabetic and their blood has high sugar. The blood is going to be more viscous. So the heart now, which is trying to get that blood out of that left ventricle, is going to have to pump that blood to your brain and your toe and do all of that perfusion stuff that we know that the heart does, which we want it to do. Well, if that blood is thick because of high sugars, for example, that thickness, that viscosity, is a resistance. It's a form of resistance. If you smoke cigarettes, right, which we shouldn't be doing, nicotine enters into your body, and nicotine is the exact opposite that nitroglycerin is. Nitroglycerin is a vasodilator, so we can imagine that nicotine is a vasoconstrictor. And it being a vasoconstrictor, it just means that the diameter of the vessel through which that blood is going to have to be going through is going to be a lot smaller. So imagine if you're diabetic and on top of that you smoke, so now you have really high, thick, viscous blood, right, with a small pipe or tube to pump it through. So imagine the heart. So generally speaking, the heart will go into compensatory mode, and two things will happen. One, it'll go into palpitations, so it'll beat faster to try to meet up for that the lack of perfusion that the body is sensing, right? Or it'll go into cardiomegaly, and a lot of people will do a scan of their heart, and the doctor will say, "Oh, your heart's slightly enlarged," and that's really a sign that something is happening in your system where your body feels the need to compensate. And it could be atherosclerosis, it could be buildup of plaque, it could be a whole bunch of other issues. It could be inflammation, inflammatory process. Bottom line is the heart needs to be able to get that blood out to the rest of your body, which is what we call perfusion, and we assess for when we go into our patient's room every time, right? With pulses and all the rest, CMSTP and all that good stuff. So perfusion is important, and so having a good cardiac output is important, and understanding that there's a systemic vascular resistance, which we'll talk about shortly, right? And we're going to throw a new fancy word in right now. We're going to throw in afterload, and afterload is nothing but the peripheral resistance against which that heart or that left ventricle has to be pumping, right? And so the size of the ventricle, the wall, blood pressure, all of that is going to make a big, is going to affect cardiac output. So, and then contractility as well. And remember, cardiomegaly is basically ventricular hypertrophy, enlargement of the heart muscle, without necessarily an increase we'll get to that in the next slide. But the point of cardiac output is to understand that there's a preload, which is the volume of the blood in the ventricles right at the end of remember, the diastolic allows for that inflow, right? And afterload is the resistance against which it has to pump. And we want to try to always reduce that afterload if there is a systemic vascular resistance. So with what I just said, what do you guys think the answer to this question is, right? So patient is receiving a drug that decreases afterload. So we want to try to release that systemic vascular resistance. To evaluate the patient's response to this drug, what is the most important for the nurse to assess? So remember, afterload, and I just mentioned it earlier with the ventricular hypertrophy and the enlargement of the heart muscle, right? And the things that affect afterload really are the size of the ventricle, the wall tension, how tense that wall is, and the arterial blood pressure. So the answer to this is afterload will be greatly affected by blood pressure, and it makes sense. If you have a high blood pressure, right, it just means that there is going to be more resistance because there's more tension and even possibly less flexibility, more rigidity in the blood vessel that the heart is having to beat against. And so a drug that decreases that afterload, make sure you always do check their blood pressure as well. The vascular system has basic blood vessels. We know there's arteries, arterioles, veins, venules, capillaries. We know that. This is an image, and as we move forward with science, this image right here, and we won't go into any detail of this, but the inner lining of the vessel, a lot of the research that is coming out now in science is really pointing out to a lot of the chronic conditions that we're seeing, whether it's diabetes, stroke, heart attack, and so on and so forth, are really based off of, generally speaking, two problems that we're seeing in the body. One is oxidative stress, right? Reactive oxidative species and antioxidants are very good for that, food, fruit, berries, so on. And another thing is, apart from oxidative stress, an inflammatory response. So remember, inflammation is good or bad? And you guys already know that the answer is it depends. Inflammation is good when it's acute. It lasts 2 weeks, after which it goes down. That's good, all is okay. If the inflammation continues to happen chronically, that's when the problems start to happen. And that's the underlying, it is believed today, the underlying problem of a lot of, or most of, or all of, in many cases, the conditions that we're seeing, from diabetes to myocardial infarction to stroke, right? The big killers that we're seeing is that at the cellular level, you were having what they call them now advanced glycation end products, or AGEs, which are proteins that with exposure to carbs or sugars, and they're using these even now as biomarkers for aging, but they lead to a lot of the degenerative diseases like diabetes, atherosclerosis, chronic kidney disease, Alzheimer's disease. And I bring all of this up on this slide because it's at the cellular level that all of these processes are happening, and so it's important to keep this in mind as we move forward. So how do we regulate the cardiovascular system? We have the autonomic nervous system, which includes this sympathetic and the parasympathetic response. We have the baroreceptors, chemoreceptors. We're not going to go into that with much details right now. Baroreceptors, we'll go that over later. I believe there's another slide that we should be able to get to that point that I had in mind. Structures and functions of the cardiovascular system. So when you think of the cardiovascular system, not only as a muscle, as an endocrine producing thing that can produce some enzymes, perhaps it's not really an endocrine, but it will affect the endocrine system. It's an electrical system. It creates conduction, but the key things to remember from a nursing perspective really are blood pressure, systolic and diastolic. And what is blood pressure? So here, this is a key thing. You guys really want to understand this and remember this equation, because it's extremely important to know that blood pressure is the cardiac output times the systemic vascular resistance, right? So these are the two main factors that will influence blood pressure, is another way of putting it. And you know that systolic, we ideally use 120/80 as the main norm, but you always want to ask the patient what their norm tends to be, or go back and look at multiple readings to see where their baseline has been. Never go off of one and only one. All right. Measuring the blood pressure, you guys have already done all of this and have and are doing it in your clinical settings in the hospitals. So we won't go over that right now because we have already covered it. And Doppler, we as I mentioned earlier, is basically an ultrasound way of detecting if there's pulses, if there's blood going through the vessel or not. And if you have a patient who has in his lower extremities, you're unable to check or feel any of the pulses, just go grab a Doppler and check it out, and then just chart they're present with Doppler. They would still be a 0 palpably, but that doesn't mean they don't have a pulse if the Doppler is showing up as present. This is something that I think is often overlooked, unfortunately, the pulse pressure I'm referring to. And really, it's the difference between the systolic and the diastolic. So the top minus the bottom, right? It's normally about 1/3 of the systolic. So if for example, if you have, let's say, a blood pressure of 120/80, your pulse pressure will be 40, right? And why is this important? Well, for a couple of things. As we age, the vessels, that endothelium lining will get slightly more rigid. That can affect the pulse pressure, and that goes along with aging. And we want to know that the norm for blood pressure, where for the pulse pressure, where should the norm be? Between about 40 and 60, right? So it's important to keep this in mind because as we talked earlier about cardiac output, let's say we know 40 to 60 is a normal, right? Below 40, we're starting to look at possible conditions of cardiomyopathies, congestive heart failure, weakening of the heart, inability, in other words, of producing a proper good push or ejection fraction or cardiac output. And therefore perfusion would be a little bit more at risk with a low pulse pressure in a sense, whereas the opposite, for example, if it's an increased pulse pressure, that might be because you just exercised, or it could be because you have more atherosclerosis, right, in the large arteries. And so these things, such as exercise, which is a good thing, or plaque buildup like atherosclerosis, which is not a good thing, both of these things can lead to having a higher pulse pressure. So just top minus bottom, look at what number you're at, and we want you to be between 40 and 60. Bottom line with this slide. The MAP is extremely important as well because it's the average pressure within the arterial system that is felt by the organs in the body. Basically, within the arterial system, it's the average pressure across, right? That doesn't mean that it's the average of the diastolic with the systolic, right? And how do we calculate this? Well, it's right there. MAP is equal to the SBP plus 2 times the diastolic, and all of that divided by 3. So let's say if you had a BP of 120/60, that would give you somewhere around 79, 80 of MAP, right? And a MAP that's greater than 60 is needed to adequately perfuse. So this is also related sort of to cardiac output. If your MAP drops below 60, then more than likely your cardiac output over time will not be adequate, won't adequately perfuse and sustain the vital organs, the toes, your brain, and all the rest of the areas that the blood with its nutrient and oxygen has to get to, right? When the MAP falls below that number for a period of time, then your organs are going to be underperfused, and what could happen? Ischemia, right? So pulse pressure and MAP, or mean arterial pressure, are just 2 more tools that we have at the tip of our hands to determine where our patients are going or coming from, what their baseline is, and do we need to be concerned, because you might look at their blood pressure and it's normal, but it's slightly changing, but still within norm. But if you look at the pulse pressure or the MAP, those numbers may be affected before you see a change in the actual blood pressure reading. So it's important to monitor these functions. As for aging, we've been talking about it as we go through as well, right? And just generally speaking, age is a risk factor for cardiovascular disease, right? But that doesn't necessarily have to mean that age equals cardiovascular disease. If you eat properly, lifestyle is okay. And in fact, a lot of people with new readings of telomeres, whether they're lengthened or shortened, which it explains the lifespan of an individual to a certain extent, can be changed with diet. Again, back to epigenetics, right? It's important that we know that somebody in their 70s or 80s could be extremely fit, whereas somebody in their 40s or 50s could be extremely out of fit, right? And a good case in point is the sumo wrestlers, right? Now, in this case, we're talking about obese. These individuals in Japan are extremely fat. So being fat doesn't necessarily mean that you're not fit. You can be really fat and fit, and the sumo wrestlers are a really good case in point. But again, remember, let's go back to the problem of cardiovascular disease. We know that it's not only the leading cause of death in adults, in Americans, but also in adults that are above 65 years of age. And then also, really, it's kind of difficult to separate normal aging from the pathophysiological changes of atherosclerosis. And so a lot of times, oh, you got plaque buildup, and that just goes along with aging. So the truth is that a lot of the physiological changes within the cardiovascular system of elderly people are a result of a combination of that aging, but also of the disease itself that they may have, like diabetes or hypertension, the environmental factors and the lifestyles, and their health behaviors rather than just age alone. So yes, age puts people at risk, but everything else, all the other factors need to be taken into consideration. Age does not mean your equal problem, is what I guess I'm trying to get at. So a lot of the changes that we do see with increased age is the amount of collagen that you'll see build up, right? The heart increases, and elastin is going to be decreased, which again goes to that endothelial lining of the blood vessels, which make it more rigid, less rigid, creating thus more systemic resistance or less. And these changes affect the heart muscle's ability to stretch and contract. Is essentially one of the big things, right? Decreased response to stress. So the more stressed they're at, they're unable to deal with it properly. And really, basically with stress, what you're seeing is there's a decrease in cardiac output and due to reduced contractility, right? And the heart rate response and ability. And also, heart valves are going to become thicker and stiffer due to that, all that lipid accumulation or the degeneration of the collagen, fibrosis, right, and so on and so forth. And this will play a major role when we talk about aortic and mitral valve, which are usually the ones that are most frequently affected. And then let's skip this right now. We'll talk about that in a class lecture that we have three lectures after this. So, age-related changes. So, what happens with aging as we age? Well, again, this is just to repeat. Blood vessels are going to thicken; they'll become less elastic. Systolic could go up or decrease. A lot of times, a lot of problems we're seeing with elderly right now is that because they have a history or an active diagnosis of hypertension, we put them on multiple antihypertensives, send them home, they get dizzy, fall, hit their head, and the complications in a lot of these patients is that it's now starting to believe that we should not be treating elderly patients too aggressively to control their blood pressure, because it seems to be that a lot of the serious complications are coming from a hypotension as opposed to hypertension. Orthostatic hypotension, you guys already know what that is. And, you know, they think a good number of patients that are over 70, 30–40%, again, may be related to the medications that patients are getting. And postprandial hypertension, which is basically a decrease in blood pressure of at least 20, that occurs, you know, within, I don't know, an hour or so after eating, can occur in at least 1/3 or half the older adults in our nation, which is a concern, right? So that's something that we could keep in mind when we educate our patients in terms of food and how it relates to possibly dropping their blood pressure after eating. So they need to be forewarned and made aware. When you do your subjective data, we have to gather quite a bit of information, the history of present illness, past history, current medications. We'll do the whole MedRec, which again is that big bag of medications and which ones are you taking, which ones are you not, when was the last time you took it, and so on and so forth, right? Also, what history of surgeries do they have as well? We want to know where they're at in terms of health perception, right? Do you practice any preventive measures to decrease the risk factors? Do you take supplements? Have you noticed increase in heart symptoms, palpitations, so on and so forth? Do you smoke? What's your diet like, right? Although nutritional metabolic pattern is more of that, what's your diet like? Do you eat salt, fat, and how much fluid do you take? So on and so forth. Elimination pattern is, are you able to not only eliminate in terms of stool, which is important, but are your ankles swelling up, for example, right? How far up do they go? Is it more difficult for you to put your shoes on now than it was yesterday, and so on and so forth. Also, we'll ask about how much they exercise or if they have a lack of exercise. For functional health patterns, how they sleep, their cognitive perceptual patterns, such as dizziness, fainting, difficult to remember things, memory, right? And so on and so forth, play a major role within the heart, because again, the heart should be pumping blood with proper cardiac output and not that much resistance peripherally. If blood gets to the brain, these cognitive perceptual patterns may not be present. So sometimes these patterns that we see could be, yes, Alzheimer's, dementia, and so on and so forth, but they could also be related to a decrease in cardiac output because the heart is now weaker. And we see this sometimes in the elderly, as their heart just beats, it becomes weak. And self-perception, what they see themselves like, and what do they think of their diagnosis of having heart disease is good. But the sleep is perhaps of these one of the most important, because we want to find out if they're how do they sleep? Do they sleep flat, or do they have to sleep with a bunch of pillows, right? And if they do stay with pillows, we always want to ask how many pillows, 1, 2, or 3, right? In fact, there's the measurement, the orthopnea measurement of how many pillows they use can help us determine how bad their condition is. There's the role relationship. Has this affected you in your day-to-day life, in your sex life, with your partner, with your friend, with your spouse, with your children, with everybody else, right? Sexuality, is this, if you're taking certain medications, right, they may lead to erectile dysfunction, could play a major role in fact, Viagra was found as a side effect. The main side effect of Viagra, when they were looking for it for other reasons, was erection, right? They had an erection, and so they changed the profile of the drug to give it as a treatment. But again, it has its risks as well. Coping, are you able to cope and tolerate? How are you dealing with the problem? Do you have people next to you that can help you? And your value belief as well. What values or beliefs do you have that might help you with your illness or during the illness, right? Or anything that might conflict as well. And religious patterns and beliefs may affect whether we give them blood, if they're Jehovah's Witness, and so on and so forth. These things are things we always want to ask our patients. So genetic risk alert, right? So coronary artery disease, and it's especially related to lipoprotein genes, have been identified in a lot of people with coronary artery disease. And cardiomyopathy can be caused by an autosomal dominant problem. Or dilated cardiomyopathy could be caused because of autosomal or X-linked dominant mutations as well. Hypertension, as we already know, really is from a complex interplay. There's not one problem. It's really a symptom. It's not an etiology. It's not a cause. It's a symptom that at the genetic level and the environmental level, again, this is epigenetics at its core right here, and that the lifestyle choices that your patient, like smoking, lack of exercise, can trigger the tendencies towards having hypertension. And so keep that in mind as well. I have let's see if we have, since we're here with the lipoprotein, I'll make a quick comment that, there's been a really strong focus on cholesterol as being the main cause of heart attacks and strokes, but a lot of research is showing that to be misguided, right? And that a lot of the clinically proven indicators of a lot of cardiovascular disease, including the elevated TGs or triglycerides, insulin, cortisol, C-reactive proteins, play a role, but not necessarily high cholesterol. In fact, in a lot of the aging people, which is important to know, people with cholesterol, low cholesterol, tend to be more at risk. And this is unfortunate because a lot of medical studies show that lowering your cholesterol really won't actually lower the risk of a fatal heart attack or a stroke, right? Like one of the directors of the Framingham Heart Study, I forget his name, said that people with low cholesterol, lower than 200, suffer nearly 40% of all the heart attacks. That's somebody with lower cholesterol. And a lot of people are taking statins, right, for example, to lower that. And yet we know that nearly 40% of people that have heart attacks had a cholesterol that was lower than 200. So don't jump to cholesterol as the bad guy of the picture. A lot of it, again, is going to depend on your alleles and how you process fats and so on and so forth. In addition to which, people that have low cholesterol, let's say less than 180, actually have 3 times as many strokes as the general population. So that's just something to keep in mind. Objective data, you already know what we need to do. Vital signs, peripheral vascular system, inspect, palpate, auscultate. We know where to palpate for arteries. This is very important to always keep in mind because it helps us do our head-to-toe physical assessment properly. All patients take medications, right? For example, that's the aortic, pulmonic. The herbs is in between the pulmonic and the tricuspid, and then you have the mitral valve or point of maximal intensity. And again, since we're in cardiovascular, let's go back to the basics here. When you go to listen to that mitral area, that mitral, that PMI, right? If you feel that it's no longer in the 5th intercostal space, but it's now expanded and you're hearing it more in the 6th, what could we think of as a possibility that maybe some scan could confirm? The heart might be enlarged and you're hearing that point of maximal intensity at a different intercostal space, slightly lower than where it should normally be, and therefore that could be an indication of that cardiomegaly. Let's see here. So with the physical examinations, we already know that the thorax, you just want to look, make sure it's symmetrical, do an inspection, listen to the pulsation, feel the pulsations, thrills, and again, that point of maximal intensity is extremely important. They also call it the apical pulse, just by the way, right? And it really is looking at the apex of the heart. That's why they call it apical, because the bottom, or the quote unquote apex, or the top of the heart, is at the bottom. That's why we call it the apex. It's in the 4th or 5th intercostal space. It shouldn't be in the 6th. And it's important that we record where we hear it. All right. Heaves are our sustained lifts of the chest wall in the precordial area that can be seen or palpated, both of them, right? And they could be caused by, again, enlarging of the left ventricle, which is, again, going to be a normal problem that we see in patients that are having increased systemic vascular resistance. Normally, you won't see any pulsations there or feel them. All right, we're not going to go into this right now. Well, one thing I will say, S1 and S2, when we're listening to them, remember we want to know, right, lub-dub, they're best heard over the diaphragm, with the diaphragm of the stethoscope, and they're going to, because they're high-pitched, right? So that's an important thing to remember, correct? Right, S1, S2, best heard with the diaphragm of the stethoscope, and we're using that because they're going to be because we want to try to get to listen to those high-pitched sounds. All right. Murmurs are graded on a 6-point Roman numerical scale based on loudness, right? And it basically from 1 to 6. If it's 1, it's barely audible. Most people will not hear a 1 or a 2. It's very difficult to hear. Maybe a cardiologist with a highly trained ear can. But when it gets to like a 6, for example, you might be in a really quiet room. If you're next to them and you put the stethoscope right, just lift off the chest wall, you might still be able to hear that. That would be considered a 6th point on the 6-point Roman numerical scale of loudness for the murmur. And the ratio is basically 1 out of 6, 2 out of 6, 3 out of 6, 4 out of 6, 5 out of 6, or 6 out of 6, which is a significantly louder murmur. Pericardial friction rubs basically it's the friction between the inflamed pericardium. So it's the pericarditis, right? Is what we need to be thinking about. They really move up against them. And again, this is going to be high pitched. It's kind of like a scratchy sound that could come and go, sort of intermittent, and they could last hours up to days, right? Now, again, why do we want to listen to the PMI or the apex? Because friction rubs are best heard at the apex of the heart, right? You want to put the patient in an upright position and have them lean forward. Upright position, lean forward. Upright position, lean forward. Tell them to hold their breath, right? Following an expiration. And this is basically going to help you get in, because you want to push that heart forward. And this is a little bit more difficult in people that have more adipose tissue, obese people, but bringing that body up and forward will help position the heart in a way where you can actually hear the high-pitched, scratchy sounds a little better. Remember, record any abnormal sound that you hear, any abnormal sound. So we're moving into biomarkers, and biomarkers are really important to understand, because if the heart, which is a muscle built of cells, when those cells are injured, remember the problem is at the molecular cellular level in the endothelium lining, with oxidative stress and inflammatory response that is leading to a lot of the chronic conditions that we're seeing. Well, when these cells are injured, they release certain contents, enzymes or proteins, into the blood. And we measure these enzymes or proteins, which are the biomarkers. And we use these biomarkers to help us in the diagnosis of heart problems, right? A very specific or heart-specific enzyme is troponin, right? And the heart muscle protein, it's a heart muscle protein that will be released into the blood after injury or infarction. So if they've had, but some people who exercise like professional sport, they may have slight troponins in the blood because they're overworking their heart. That can happen. So it's, but for the most part, injury or infarction is what we're really going to see it happen. And there's 2 subtypes of troponin, the T and the I. And we won't go into this detail right now. Normally the blood level should be low of troponin, or low to none, right? So any rise in these enzymes or proteins is really a diagnostic form. We can almost conclude that yes, okay, their troponins are going up. Now, mind you, if a patient's going into a procedure and they just had a stent placed, or they just had a cardiac catheterization, and they come back, they may come back with much higher troponins than they had when they first came into the hospital in the first place. And we'll have to notify the doctors, of course, if it's a very high number. Hey, doc, numbers are up. But what we'll see is that they'll slowly trend down after that over time, right? And on average, about 4 to 6 hours after they'll peak anywhere around 8, 9, 10 hours, some up to even a day. But they can be detected for up to 2 weeks after they've been in the blood. And so again, the biomarker of choice for heart issues is troponin. We do have other biomarkers, such as the creatinine kinase, which is an enzyme that's in quite a few tissues. Most skeletal muscle, a lot of the brain or neurological tissues, but also in the heart. So it's only the CKMB, which is specific to the heart. they're not doing these as much. Troponins is much more the go-to biomarker today, but you may see this in exams, NCLEX, and whatnot. And the CKMB, what's important to know is they peak within 12 to 24 hours, and after about, I don't know, 24 to 48 hours after the MI, they should start to go down. And that's important to know. And myoglobin really elevation is it's an indicator of early heart problem, but it's not specific. So a lot of I don't think they're using it as much as we used to. And so this is just an image to show a little bit of how long, when it peaks, how long it stays in your body. And one of the best ones that we use now is the troponin, because we can measure it. Let's say they had a chest pain 5 days ago and it took them that long to come to the hospital. We probably want to be doing troponins, which is what we would be doing. There are other cardiovascular biomarkers that we can do, like CRP. And CRP, the problem with that is it's made by the liver, right, during acute inflammation. And again, remember, acute inflammation is a good thing. And let's bring our minds right now back to the endothelial lining of the body, where all the cells are, where a lot of the problems start to happen, right? If you take a hammer and hit your thumb once, boom, your thumb is going to grow up and expand and become inflamed. If you don't do anything and allow that thumb to rest, that acute inflammation or swelling, which is what inflammation is, will go down after about 14 days, 2 weeks. But what happens if, let's say, before that acute inflammation goes down, you take the hammer and you hit the thumb again, and swelling happens again. And right as it's going down, you hit it again. Now we enter from acute, we enter into chronic inflammation, and it's that chronic inflammation that we don't want to have. So if you are consuming foods that are very pro-inflammatory, not good. We want anti-inflammatory foods, right? Whole foods, not the pro-inflammatory foods. If you're eating pro-inflammatory foods, every time you ingest that soda or that sugar or that processed meal that we so much love, it's like the hammer hitting the thumb. You're not allowing your GI tract, you're not allowing the intestinal lining to heal itself from chronic inflammation. And so CRP is used for a lot of times for acute, but it can be used as well for chronic as well. And there's a higher sensitivity test. They call it the HSCRP, which is believed to be even significantly better than that. And again, what is this looking at? Well, basically, let's go back to the basics. The presence of atherosclerosis, which is usually what happens and ultimately leads to a lot of the cardiac events that patients are gonna have. It's also can predict the risk for future cardiac events that a patient. So, are you going to have an MI? We'll look at your CRP. And there's a lot of natural ways to bring it down with certain B vitamins, B12, B complex, and whatnot. We won't go into that here. However, CRP is considered. It's not routinely done, but if patients do have a heart problem, it's probably not a bad idea. And you might see a lot of your patients in the hospital that are starting to get the C-reactive protein red. Homocysteine is another one. It's basically an amino acid. It happens with catabolism or the breakdown when the proteins are breaking themselves down. And they can be hereditary in the family, but they can also be deficiencies, again, of B6 or B12 or folate. And again, they are linked. A high level of homocysteine is linked to a lot of coronary vascular disease, including peripheral vascular disease and stroke. And so you may start to see a lot of your patients in the hospital get that as well as a part of the blood lab checkup. Further biomarkers or blood studies are ANP or BNP, which is the brain natriuretic peptide, and those are mostly from the ventricles as opposed to the ANP, which is from the atrium. And BNP is considered, and now it's the marker of choice to distinguish if a problem is a respiratory problem, like if somebody's having a shortness of breath, let's say dyspnea, right? How do we know it's respiratory or cardiac? Well, we do a BNP, and the BNP will sort of guide us to determine the difference. Now, for the longest time, BNP was and still is the hallmarks blood lab drawn for congestive heart failure, right? And that's true, but it's much more than that, right? It was the BNP was discovered like 10 years ago. It's actually a hormone that the ventricles, that your heart produces, right? And it is a marker for diagnosis, as I said, of heart failure. But what's even more is a predictor of death in people who even have a stable coronary disease that have no symptoms at all. They're just, quote unquote, doing fine. So if your doctor says you're doing fine and you have a high BNP, that's something to think about, right? And a lot of the research has said if your level is, let's say, above 400, you're going to be 8 times more likely to die in the next 1 to 5 years than people who have a BNP under 100, right? If you so keep in that. Some people even say if you're above 80, right, BNP, it can raise the incidence of death to by 5 times, 5-fold increase. And if you have above 500, that literally predicts risk of heart attack, again, from 5 to 8-fold within the next 4 years. So you can imagine how important BNP is. It's quite important to look at. And let's go on to the next one: serum lipids and triglycerides. So we have quite a few labs that we can do. We won't go into these in any details. Triglycerides are the main storage of lipids, right? That's most of the fatty tissue, up to, I don't know, 80, 90, almost most of it, right? The cholesterol is basically your cell membranes. The biphospholipid are made out of cholesterol, right? And we need to have cholesterol in our body because it's a precursor to every single steroid, corticosteroid, sex hormones, and your bile salts in the body as well. So keep in the and we need to remember that cholesterol is synthesized in the liver. So we want to make sure our patients have good liver enzymes, a good liver, so their AST and ALT is normal as well, because otherwise it won't be able to produce or synthesize that cholesterol. And like the lipoproteins, which are synthesized by the liver as well. Now the serum lipids will flow throughout the blood, and they're bound to a protein, and that's why they call it a lipoprotein, right? That's what fats are. They bind to a protein. We call them lipoprotein. And apoproteins are just water-soluble proteins that combine with most of the lipids to form the lipoproteins. There's quite a few things that we could look at as well. Actually, I'm not going to go into that right now. So other diagnostic studies that we can do, there's basically 4 classes of lipoproteins. There's the chylomicron, there's the LDL or low density, there's the HDL or high density. We want the high density. High density, or the HDL, is called the good guy, the good lipoprotein, and you want to have a higher number in that. And then you have the VLDLs, or the very low density lipoproteins as well. Now, the chylomicrons are related to triglycerides directly from the dietary fat, right? And we do a lipid panel to measure quite a few things: cholesterol, triglycerides, LDL, HDL, and an elevation in any of what the previous slide and this one is looking at, like triglycerides or LDL, are associated with heart problems like coronary artery disease. An increase of the HDL, this is important to remember, is associated with the decrease of heart problems like coronary artery disease. Remember that high levels of HDL serve a protective role because they help mobilize cholesterol from the tissues. They move they basically go in and remove that cholesterol and help transport them through and out of the tissues. And now there is association between elevated serum cholesterol levels and coronary artery disease. A measure of the total cholesterol alone is not enough to assess that risk, right? And so I had a really quick note somewhere around here that I wanted to make a comment to in terms of that. So there's a couple of things that we could look at to determine. Oh, and I did want to mention something about the BNP. There's a lot of research that have said that an elevated BNP can be decreased with vitamin E, especially the vitamin E is basically alpha, beta, gamma, and delta, different types of tocotrienols, and it's the gamma tocotrienol. So if you buy vitamin E, make sure it's the gamma tocotrienol. That's the side note that I wanted to make. Bottom line with these few slides that we're going over here in terms of the blood levels that we do for lipoprotein and risks, I think it's important to keep in mind two things. It's the ratio that we want to look at to determine the risk of a heart attack. And there's two ratios we could talk about. One ratio is triglyceride to HDL, right? And you want to be below a 2. And all you do with that is you just divide your triglycerides level by your HDL. And if you divide your TGs or triglycerides by your HDL, it should give you a number, right? If you're 2 or less, you're ideal. Lower, better. If you're 4, between 2 and 4, that's high, that's too much, higher risk. And if you're close to 6, that's way too high. You're at high risk of heart attack. That's one of the ratios, right? And another ratio that you want to keep in mind is the triglyceride HDL ratio, and this is one of the strongest predictors for heart disease. In fact, the research coming out of Harvard said that high triglycerides, that this ratio, if you look at it carefully, it can increase your heart problems by about threefold. People with the highest ratio of triglycerides to HDL, the good cholesterol, had about 16 times the risk of heart attack as those with the lowest ratio of triglycerides to HDL. And so it's important that this ratio of TG to HDL, triglyceride to HDL, is believed up to today to be one of the strongest predictor of a heart attack. So if you have your own blood draw that you've had in the last visit to your doctor, pull it out. Look at where your TGs or triglycerides are. Look at where your cholesterol is, and just simply divide your triglycerides by cholesterol, and hopefully you're below a 2. I think that's one of the key things to keep from this slide. We won't go into in functional medicine, and if you did a much more involved blood sample, they could tell you what your lipoproteins, if the A's or the B's were present, and this can give you a lot more information. We're not gonna go into this. I will say that the lipoprotein, the A2, the LP PLA2, is really a major inflammatory enzyme, and it plays a major role back at that molecular cell level of the inner lining of our blood vessels to create atherosclerotic plaques. And so if you have an elevated level of that LP PLA2, you're going to be at major risk for coronary artery disease, especially in African American women, but in everybody across the board as well. All right, so what do you guys think the answer to this is? Patient arrives at an urgent care center after experiencing unrelenting substernal and epigastric pain and pressure for about 12 hours. Nurse reviews the lab results with understanding that at this point in time, myocardial infarction would be indicated by peak levels of, and remember, what is the biomarker of choice, usually for myocardial infarction? Any thoughts on this? Troponin. Troponin is the myocardial muscle protein that's released into the blood after any type of injury, like a myocardial infarction. It will peak anywhere between, 12 hours, up to about a full day, up to 24 hours. It's the longest lasting one. So that's the one we would be looking at for sure. When we look at the heart, we can do X-rays to look at any displacement or enlargement of the heart, right? Or if there's fluid, like if there's pericardial effusion, you want to take a look at it, or pulmonary congestion, it will show up. And so radiographic pictures of the heart can help doctors determine what's going on as well in our patients. Let's skip this right here. Just know that we do an electrocardiogram at this point to look at deviations from a normal, because if we know what PQRS is and should look like, and they don't look like that, we compare it to what the normal is, and it tells us if there's an event that is happening. All right. Let's see here. So an echocardiogram of the heart is an ultrasound. They use waves to look at the structures of the heart, right? And we know what those waves should look like in a normal heart. So again, if the waves are abnormal, the ultrasound specialist and the doctor will conclude that there could be one problem or another. If you hear the word contrast echocardiography, it just basically they make sure they have a good 18 gauge IV, and they put in a contrast agent. Remember to check for allergies first, and then it helps the image to detect, especially in a lot of obese patients, it's a lot harder to do echocardiographs. So sometimes they will go into a contrast agent. And the echocardiogram is really good to look at abnormalities of your valves, of the chambers, of the ventricles, right? The septum, how thick it is, the pericardial sac, if there's rubbing, fluid buildup, and inflammation, and also of the aorta, can look at it. They will do this to determine the ejection fraction as well. This is important to know, right? Because the ejection fraction is the percentage, it's the overall percentage that's ejected during systole. It can be measured, right? Remember, the ejection fraction provides the information that we need to know about the function mostly of the left ventricle during systole. Remember that it's the left ventricle that's going to push to the body. It's the left ventricle that tends to be a little bit thicker. So an echocardiogram can look at that ejection fraction and determine quite a few things, how bad or how good that ejection fraction. We're not looking for a full 100%, rarely even 90%. If you're 60% or above, 70%, you're good. When you start to get down to 15 or 20%, which is a lot of people with congestive heart problems, cardiomyopathies, a lot of drug users, unfortunately, you'll see that their ejection fraction tends to be significantly low. Now, a stress echocardiography is basically, you can do two things. You can do a treadmill or pharmacologic. If they have an amputation, are they going to be doing a stress echo with the treadmill? No. They can't run, they don't have a lower extremity, they had an amputation of below their knee, they will be getting a pharmacological drug that will create stress in the heart, right, to allow the echocardiography specialist to determine what the problem is, right? They use a lot of different medications to stress their heart. And the transesophageal echo just means through. It's a more precise form of echocardiography. Let's leave it at that right now. That's just an image of how they can see. They can see where the left atrium and ventricle is, and they can see more inflammatory response, thicker walls, to determine if there's any problem. Let's see here. So the most common used forms of echocardiogram are the 2D, which helps look at, again, the intracardiac structures, is one of the most important ones to keep in mind. They will use the MUGA to look at cardiac blood pooling as a scan, and it looks at the walls of systole and diastole and the heart valves and ejection fraction. So it's another way of, it's another nuclear scan to do to check for problems of the structures. The one that they use to diagnose the coronary artery disease, more of a prognosis for coronary artery disease, is the perfusion imaging. that they can use. Now, the exercise stress perfusion imaging is preferred, but again, if a patient can't exercise, they may need to get some type of stress test, and we just need to monitor that they can get rid of that isotope after injection into their body. The exercise stress perfusion test will use LexiScan or adenosine to stress the heart out if the patient can't exercise for any reason. All right, let's go to the next one here. And in this one, one thing that I'd like to bring up as an important thing for nurses to keep in mind is if patient has any metal, right, you want to watch out that in some patients that have stents, the stents may be magnetically safe, but in other cases not. If they're recently out of a stent placement, don't send them into one of these magnetic resonance imaging. It could dislodge it, and it can take quite a while to allow it to. So confirm with the intensivist or the hospitalist or the cardiologist before sending your patient to a magnetic resonance imaging, which is used. It's like the CT, for example, is used with or without IV, like a lot of the other things, and it looks at, again, the anatomy, circulation, the blood vessels, to determine a diagnosis of heart disease as well. The CTA is basically a non-invasive test. It's faster than a cardiac cath, less risk and discomfort clearly to the patient, but they have to be in a normal sinus rhythm to do that. If they're not, if they're in AFib, if they're tachycardic, they may not end up wanting to do a CTA. All right, so let's move on. Again, that was just an image of right there. I believe that is buildup of plaque, artery plaque, or atherosclerosis. Cardiac catheterization is really common. If you work on a floor, a telemetry floor, you'll be doing these left and right. You can go in through the right groin, through the left groin. They're now doing it through the radial as well. I like the radial. It's safer, but not all surgeons are trained in that. It's I've had more bleeds in my personal experience with patients who go through one of the femorals, and when they come back, you have to be monitoring for risk for bleed. The problem with the cardiac catheterization is that the risk for bleed, if your patient comes back and they're bleeding and the blood's spurting everywhere or blood coming out, that's great because you can see it. The problem is when you don't see it and the bleed is accumulating below. So you want to bilaterally palpate those areas to make sure, every 15 minutes times 4 times, every 30 minutes times 4, every hour times 4, until the patient is relatively safe. But you want to palpate bilaterally so that you can determine if there's blood accumulating underneath in that femoral area where the doctor went in to do the cardiac catheterization. And this is both a diagnostic test, but it's also an intervention. They can go in and look at intracardiac pressures, O2 levels. They can look at cardiac output and ejection fraction. They can do a lot of things, but they can also deploy a stent as well. The coronary angiography is done mostly with the left side heart catheterization, and I'm not going to go into that at this point, but it will use a contrast medium, so make sure their kidneys are good and they're able to urinate, and you flush them down with fluid unless they have a contraindication to do so. That's just an image that shows a normal left coronary and circumflex artery, and that's what they can look at in real time when they go in to do a cardiac catheterization. We can do intravascular ultrasounds, which is an invasive procedure. And we can do a fractional flow reserve. I'm not that familiar with that, but it looks at a lot of the pressures and the flows within the coronary artery. You'll see more of these perhaps sometimes in ICU. And the EPS is just looking at the electrical activity of the heart using electrodes that they place inside the heart chamber. So it's pretty invasive. They have to go into the heart, but it gives a lot of detail in terms of the SA or the AV or the ventricular conduction. So in many very specific cases, they may need to do this. And Lo and behold, ladies and gentlemen, we are done with today's lecture. That's, wow, hour and a half of talking nonstop. So hopefully you've gotten good information out of this talk. And remember, I guess, take a step back. Remember, it's the #1 killer, and lifestyle makes a major impact on it. And so we don't want to come up with any flat statements such as fat is good for you or fat is bad for you, or coffee is good for you or coffee is bad for you, because we don't know what that individual is. We're moving into an era of personalized medicine, and don't let any nurse ever come to you and say that knowing this type of information is not important. It absolutely is. And in fact, we're healthcare providers. And so if we're going to be talking to our patients and providing information, please provide accurate information and keep up to date with the information. It's extremely, in my opinion, extremely exciting what we're starting to find. I mean, for God's sake, we know now who should be eating a high fat and who shouldn't, who should be drinking coffee and who shouldn't. Wow, to me, that's amazing. That's fascinating. I think all healthcare providers should be following this, and that's just my personal idea. Ultimately, when you hit the floor, if you want to be so specialized and do nothing but acute care, by all means, just don't be providing information, at least from a upstream nutritional lifestyle, if you haven't been keeping up to date, because then you'll just be giving non-evidence-based information that could put your patients more at risk. And we know that as nurses, we're all about patient safety first. All right, you guys have a good rest of your evening.